you, Corey, for having me back again this year. So we're first going to talk about managing pain and fatigue, and I tried to do this talk gearing it towards lung cancer. So anyway, this is a study that looked at oncologists and patient perceptions separately of the importance of treating pain and fatigue. So how do we and patients value? So 41% of patients said that the most important thing for them to have treated was fatigue, pain 34%. But oncologists overwhelmingly chose, they would think that patients would want their pain treated more than fatigue. I think when I look at this, it really surprised me too, because I would think I would never want to be in pain. I would want, I'd rather be fatigued, I don't know. But I also think that oncologists answer this way because we know how to treat pain. We have lots of drugs in our repertoire to treat pain. But when it comes to fatigue, a lot of times we throw our hands up and we're not really sure what to do for patients. We can't usually just take the script pad out and write something down. The NCCN guidelines definition of cancer-related fatigue is a distressing, persistent, subjective sense of physical and or emotional and or cognitive tiredness or exhaustion related to cancer or cancer treatment. And it's not proportional to recent activity that interferes with usual functioning. So this is a study that looked at treating fatigue in cancer patients. Now this is stage 4 cancer patients. This is not specific to lung cancer. And that looked at 160 patients who reported moderate or severe fatigue. So only 16% of them received any general strategy or specific counseling to treat their fatigue, and 36% received some kind of pharmacologic management of any kind. So again, shows that a great proportion of patients who report significant cancer-related fatigue go either uncounseled or untreated. Obviously, there are lots and lots of different things that patients could be having wrong with them that could relate to their cancer-related fatigue. Pain, medication side effects, anemia is a big one. Not sleeping, not eating and drinking, other comorbidities. So you have to make sure that you're treating all or at least one or two or some of these before you just narrow it down to straight cancer-related fatigue. All this comes out of the NCCN guidelines, so things that you can do to manage it, and the red and the yellow are what's been updated this year. So I did this talk last year at this conference, so I wanted to put in what the NCCN guidelines updated this year. So everything else in black and white is the same thing. Set priorities, delegate to other people, ask for help from friends and family members. And sometimes it's helpful when we're seeing patients in the office as doctors or nurses to tell the patient in front of their caregiver, it's okay for you to ask for help. Because sometimes when you're the patient, you don't want to ask for help from other people. I can sort of relate to this as just having a baby. If somebody volunteers to help me, I'm like, yes, please. But I don't necessarily go out and say, hey, can you come over and make me dinner tonight? Because I'm exhausted from feeding this baby all day. So sometimes it's good for us as practitioners to say it in front of the caregiver, because then the patient didn't have to ask, but we've told them it's okay. And maybe that would prompt the caregiver who's in the room to, then help out a little bit more. But I thought this was interesting. One of the guideline updates in the yellow box there, set priorities and realistic expectations. So, again, if a patient is on, a pretty strong chemotherapy and they're saying, 2 days later I'm going to go, on a hike or something like that, that might not be the most appropriate thing, and that might be helpful for us to bring that up. And then in the red box also, helping the patient find meaning in their current situation, meaningful interactions. So maybe prioritizing, one thing that you want to do versus another. There's, again, a list of non-pharmacologic things you can do. So the 3 main things that I put pictures up of is depression, exercise, and nutrition. So these are probably 3 things that we can do non-pharmacologically to help patients with their fatigue. And the depression thing isn't just prescribing medications. It's getting them counseling, having them speak with someone, and with family members as well as by themselves. Pharmacologic treatment, so what can we give them? What can we prescribe? Consider the psychostimulants. Methylphenidate is Ritalin. Modafinil is Provigil. So, I'm just going to throw out the brand names since these are not drugs that are necessarily in our oncology repertoire all the time. Obviously treating pain, emotional distress, anemia, as indicated, can be other pharmacologic things we can do. Now, fatigue in the post-treatment setting, maybe if you're in the curative setting post-treatment or in end of life, is a little bit different. Generally the same. If it's post-treatment, think of maybe late effects that they might be having. So say they had adjuvant chemotherapy after surgery, and then they're still having significant fatigue months and months later. You may want to work them up for any comorbidities that could be related to the treatment that they got. And then for end of life, you can consider the addition of steroids, of course. When they're not end of life, you can use steroids to help fatigue. It's not in the NCCN guidelines for non-end of life patients. Obviously, you'd want to make that a short-term course. You wouldn't want to keep them on high-dose steroids for a significant amount of time. So exercise and cancer-related fatigue. This is always a big thing. People say, oh, don't be a couch potato. Get up and go exercise, and that's going to help your fatigue. Yes and no. This is definitely, in the first bullet point, definitely best seen in the breast cancer population. 19 randomized clinical trials, exercise versus none in patients. 16 were in the breast only out of the 19 randomized clinical trials that they looked at. Most of the patients that benefited were breast and prostate cancer patients. In a single study of cancer patients, the colorectal and multiple myeloma patients did not have any benefit. So it's unclear to me where the lung cancer patients fall in this. There's no direct data. The one thing that's obvious is that our patients have respiratory compromise a lot of times in addition to their cancer. So I'm not going to tell my 78-year-old COPD patient, hey, get out there and walk 2 blocks. That's going to make you feel better. Probably not, especially if they're oxygen dependent or have other comorbidities. So I don't want the patient to be a couch potato, but at the same time, know your patient, their comorbidities. A significant amount of exercise might not always be the right thing for a lung cancer patient. And then ESAs, so erythropoietin stimulating agents for patients who are anemic. I threw a little bit in there about that as well. I just wanted to be clear on what the guidelines are, and that one of the main problems here is that in more recent studies, increased risk of tumor progression or recurrence has been seen in breast, lung, head and neck, lymphoid, and cervical cancers. So you have to be, obviously concerned with that. And to prescribe them, you have to be accredited with this APPRISE program, which I'm sure you all know. They are not indicated whatsoever in any patient that you are giving curative intent therapy, so they should not be used at all in that population. Only indicated with use of chemotherapy, not for what we consider cancer-related fatigue, and should be discontinued when chemotherapy is discontinued. Again, the approved use is hemoglobin less than 10. If the hemoglobin increases by 1 gram per deciliter in a 2-week interval, you should reduce it or hold it. So people forget about that. But if you're having like a sudden jump in their hemoglobin, then you should hold back on the drug or dose reduce it. Hemoglobin, only using it once the hemoglobin increases to where you're going to minimize transfusion. And discontinue it if no response after 8 weeks. If you're giving them an ESA and their hemoglobin is not bumping after 8 weeks, then it's recommended that you discontinue therapy. And there are the boxed warnings, which I'm sure that you're aware of and need to explain to patients. Okay, let's talk about pain management in lung cancer. So again, pain management is an enormous topic that I could spend lots of time on. I'm trying to narrow it down to patients with lung cancer, and then narrow it down further to certain aspects of pain management, because you don't need to hear me talk about long-acting versus short-acting up here, because you guys know most of that stuff. This is a study that looked at barriers to pain management in lung cancer patients. So it was an online questionnaire. 92% of the patients reported that they had pain related to their cancer. 67% were unsure of the cause, 52% thought it was from cancer, and 38% due to the treatment. The number one barrier, fear of addiction. I think that is true in my population of patients. They hear the word pain medicine or narcotic, and they have a significant fear of addiction. 71% said no one recommended pain medicine for them, and 56% were concerned with the cost. 24% of them tried complementary therapies as well. So what are the causes of pain in our lung cancer patients? Because we know that there's not really pain receptors much in the lung parenchyma, hence patients have 12-centimeter tumors and have no idea that it's there. So bone mets are probably one of the number one reasons why our patients experience pain. Pleural mets, we know that anything in the pleura can be tremendously painful for patients. Direct tumor invasion, chest wall or local nerves, neuropathy from chemotherapy, and the HPO, which is, or HPOA is called sometimes, is rare but can happen. So for bone mets, obviously radiation, opioids, steroids are a good treatment. NSAIDs are usually very effective, but obviously we have to watch out what other medications they're on if you're going to prescribe NSAIDs. Samarium is a treatment that is FDA approved for bone scan enhancing mets, and that's something that we do at Penn that can be a significant help for those patients. You just have to watch their blood counts because it is myelosuppressive therapy. Neuropathic pain in lung cancer patients, so nerve can be compressed by tumor, or it can be chemotherapy-induced, which we know taxanes, vinorelbine, cisplatin are drugs that we use in lung cancer patients that can cause this. Postherpetic neuralgia is another thing that we find sometimes in our patients. Diabetic neuropathy coupled with all the above, so if they're diabetic and have neuropathy from that on top of one of the above problems. And there's no clear prevention strategy for chemotherapy-induced peripheral neuropathy. Sometimes patients talk about vitamin B or vitamin E, and I don't have a problem with them taking it, but there's no randomized data to say, taking high doses of these vitamins is going to reduce or prevent you from getting chemotherapy-induced peripheral neuropathy. So how do we treat neuropathic pain? So the anticonvulsants, and guess what? All of you got my first question wrong. So not one person picked the right drug. So it is confusing because no one knows this, but a lot of people know that gabapentin is not technically indicated. It's probably the most common drug we use because it's pretty easy and cheap to give. But neither gabapentin or pregabalin, which is Lyrica, are indicated for chemotherapy-induced peripheral neuropathy. Pregabalin also is only approved for diabetic peripheral neuropathy, so if your patient is not diabetic, you might have a hard time getting that covered. If your patient happens to be diabetic and they have peripheral neuropathy, you can probably get it through. Some of the antidepressants can be appropriate, and amitriptyline, which is Elavil, is something that we've used in the past. But there it is, duloxetine, which is Cymbalta, is the brand name, is the only drug actually ever in a phase 3 clinical trial to show improvement in chemotherapy-induced peripheral neuropathy. Now, this is probably because there hasn't really been phase 3 trials of the other drugs for chemotherapy-induced peripheral neuropathy. There's been trials looking at peripheral neuropathy, but not something related to chemotherapy. So something to think about. Especially if you're trying to get drugs approved. Opioids, transdermal lidocaine, the lidoderm patch, that bottom bullet, just the supportive care and cancer issue, like I think this month or last month, just showed a clinical trial that was randomized. It was a small study, but it did show an improvement in treating neuropathic pain in cancer patients. I have not been able to get the lidoderm patches approved often for cancer-related pain. It's been a real problem just in the past year. I used to have no problems, but now the insurance companies have really started denying it. If you really want it, you could reference that trial. It's small, but it did show an improvement. HPO or HPOA, again, is a cutaneous and osseous proliferation at distal extremities. So these are your patients that come in with significant joint pain, knees, ankles, wrists, elbows, usually. Again, lung cancer comprises 80% of these cases. So while they're rare, it mostly happens in our lung cancer patients. Obviously, the treatment is to treat the cancer because the cancer is the cause of it. So if these patients go to surgery or have a good response to chemotherapy and radiation, often the symptoms get better. For those patients where the symptoms aren't getting better, treating the cause, or treating with NSAIDs actually tends to be a good thing for it. And actually, indomethacin is probably the best drug for this. But again, if they're on any kind of anticoagulation or having renal problems, it's not going to be a good drug, so always think about that. And then I put in methadone because it's a drug that, as oncologists, or at least at my center, we're all a little bit nervous about prescribing. We tend to send them to palliative care or pain management. But I wanted to throw it out there because it's not something that we're always comfortable with prescribing. What are the pros and cons of giving a cancer patient methadone? The pros, it's good for the end of life. It comes in liquid, so it can be rapidly absorbed through the liquid. It's long-acting, So that, you'll see it's in my con list too, the long-acting, but it is long-acting. No hepatic metabolites, so you don't have as, problems that you might have with morphine in elderly patients where they can get confused and really lethargic. It's really inexpensive, and it has a low street value. So those last two are also really good options for us. What are the cons of methadone? Long-acting, so that was one of my pros, but the mean half-life is actually 15 to 60 hours. It's a huge range, and it's a long time. So if you give somebody a dose and it doesn't agree with them or they're having problems, it's going to be a heck of a long time until it gets out of their system. So that can be a con. Has a stigma. We have certainly prescribed it for patients, and they're like, isn't that what you give heroin addicts? Well, the answer is yeah, but it can also work well for you. So there's a stigma there that some patients don't like. And sometimes the equianalgesic dosing can be hard. So if you have a patient who's already on morphine or fentanyl or OxyContin, and then you're trying to switch them over to methadone, sometimes that can get a little bit confusing, and I call on my pharmacist for help for that most of the time if I'm going to be prescribing it. So pros and cons sometimes can be good, sometimes can be difficult depending on who's prescribing it. Then the Oncology Nursing Society has guidelines for non-pharmacologic interventions for pain. So, things like massage, heat or ice, positioning, acupuncture. Acupuncture is a big one. There is data for that, and it's something that can help pain as well as a lot of other symptoms that patients are having. So I strongly recommend it to patients of ours have had significant improvement, both in fatigue, nausea, pain, a lot of things. They can get benefit from that. And then, there's lots of other things, relaxation training, guided imagery. Pennsylvania Hospital is a hospital up the street from us, and they have really good programs like this for patients who have pain and fatigue. So to summarize from this portion, pain management, it's important, it's treatable, we should be advocates for our patients, knowing what the source of the pain is. Patient says like, oh, I have pain, in my chest here. You can't just say, oh, blow them off, they're stage 4 lung cancer patient, I'm sure it's from, try to work it up and see what the exact cause of the pain is, because that can be helpful in treating it. Know what the available therapies are and what the pros and cons of the different therapies are for the patients.